Hello everybody, welcome to this Breas webinar. My name is Calvin Louis, I'm the Global Application Manager at Breas, and I'm very happy to welcome you to this webinar about some of the unique features of our mechanical insufflator, the Clearway 2. As you know, this is a monthly webinar where we will switch between topics around ventilation and topics around airway clearance. We of course welcome your questions during this webinar, and we will ask you to use for that the chat function, which you find in the upper right corner of your screen. When you drop your questions there, Michelle will answer them at the end of her talk. Please also note that the recording of the webinar will be available within a week or two on our educational platform, educationbybreas.com. All that being said, I would like to hand it over to Michelle for her talk on the usage of IPPB and stepped insufflations with Clearway 2. Michelle, thank you very much for this talk, and the floor is yours.
Thank you so much, Carl, for your introduction. Let me just share my slides with you. I will do the usual and just check that you can see them before I start.
Yes, we can.
Perfect.
Everything's clear.
So I'm just going to take a moment to go through our roadmap of my presentation. I'm going to be looking at what is IPPB and the physiological benefits for using this technique, the evidence base for IPPB, and based on that, what patients we should select for the usage of this technique. I'm going to look at IPPB as a method of airway clearance and how we can utilise it for proximal and peripheral airway clearance, and then focus the last moments of my presentation on the technical application of the Clearway 2 with regards to IPPB and stepped insufflations. So before I start, I just want to highlight that intermittent positive pressure breathing, or IPPB as it's shortened to, was first described in 1947 by Motley and co-workers. And Barbara Weber in 1988 described this as an adjunct to chest physiotherapy, but highlighted that it goes in and out of fashion. And this is because the literature is fairly old, often it's forgotten, or it has been surpassed by that of the non-invasive ventilation evidence base. And some of the early work in IPPB wasn't correctly targeted and therefore provided negative results. So we've got a technique that comes in and out of fashion where the evidence base could be a little bit dicey. So looking at what IPPB is, it is maintenance of positive airway pressure throughout inspiration with the airway returning to atmospheric pressure. And this looks like this. So you must trigger the breath, and that's the squeeze on the lung model. And then the device cycles into inspiration, and then it allows the patient to passively breathe out with no positive expiratory pressure. It can be delivered via a mask or a mouthpiece, and that's a key thing to remember because we can utilise what we want to deliver that to the patient. So if we look at what happens, normally when we're self-ventilating, we'll have a certain tidal volume that will occur. When we use IPPB, what we're aiming to do is increase this tidal volume. So we're augmenting a greater tidal volume, and we're looking for at least 25% increase in the tidal volume compared to what the patient can do by themselves. As I highlighted, that non-invasive ventilation seems to have taken over from the practicalities of being used rather than IPPB devices. And we need to remember that when we are targeting non-invasive ventilation, which I put here in purple, We are just trying to augment a normal tidal volume for the patient, and we are trying to offload the work of breathing and correct ventilation. Intermittent positive pressure breathing is a technique that we are augmenting a greater tidal volume than what would be normal. And that is a key point to remember. So if we just look at these two techniques as a comparison, if I summarise, non-invasive ventilation aims to decrease the work of breathing whilst maintaining a normal tidal volume. It improves distribution of ventilation, and thus, because we're ventilating the patients, will improve oxygen and carbon dioxide levels. IPPB has the same and similar effects in that it also tries to decrease the work of breathing, but it's increasing the tidal volume. And that will help us from our airway clearance perspective by creating an expiratory airflow bias. It will utilise the channels of collateral ventilation to aid secretion movement. It will also improve distribution of ventilation, and hopefully we will improve oxygenation and carbon dioxide levels. Before I move on to the IPPB evidence base, I want to pause and take a moment to look at the non-invasive ventilation evidence base for it being used as an aid to physiotherapy, because this evidence base is more recent than, per se, the IPPB evidence base. And this is work done in a group of cystic fibrosis children by Brigitte Ferrou's group in France. This table looks at a controlled session of physiotherapy versus a pressure support session of physiotherapy. And I hope that my arrow is working and that you can see where I'm pointing.
Yes, Michelle, that's clear. We can see that.
Perfect. Teams is updated, and finally that happens automatically. So what was interesting in the table is that there is no difference in baseline parameters between the control session and the pressure support session. However, when we look here at the controlled session, you can see for the oxygen saturation, which I'm pointing at now, there is a downward trend for the oxygen saturation in this patient at the point of the arrow. The arrows represent the forced expiration technique, or HUF as it is known. So after the individual has huffed, the oxygen saturation drops, the respiratory rate goes up, and we can see some fluctuations in heart rate, but we have this progressive desaturation. When the physiotherapy session is combined with the addition of ventilatory support, this trace is much more stable. There is less desaturation and less variation in the heart rate. And what they found was that if you look at the controlled physiotherapy session versus the addition of pressure support, that when they were doing physiotherapy, they became more fatigued, judging by a decline in inspiratory muscle strength. But if you added non-invasive ventilation, you had an improvement in your inspiratory muscle strength, therefore offloading the work of breathing. The expiratory muscle strength also declined in the control group, but improved in the pressure support group. Again, highlighting that we are seeing offloading of the work of breathing. And this was transposed into looking at the mean oxygen saturation, that there were better oxygen saturations in the pressure support group and a lower respiratory rate. This similar work was carried out in an adult group of cystic fibrosis patients by Anne Holland in Australia. And she also showed that the inspiratory muscle strength dropped without ventilatory support, but remained the same, therefore didn't decline with the addition of non-invasive ventilation. They also saw an improvement in expiratory muscle strength and concluded that the ventilator offloaded the work of breathing. This transposed to seeing better mean oxygen saturation with non-invasive ventilation. The minimum saturation recorded was less with non-invasive ventilation, and the percentage time the treatment was less than 90% was also better. So again, although these studies didn't look at sputum clearance, they showed that non-invasive ventilation can be a tool to aid physiotherapy. In a more recent study, Rodriguez-Hortel looked at the lung clearance index, and this is a technique that is gaining momentum. The higher the lung clearance index, the more sputum or airway inflammation is present. And they showed that with the addition of non-invasive ventilation, the lung clearance index declined, indicating improvements in airway caliber, i.e. potentially less inflammation or less sputum present. And this just shows this graphically here for the bi-level support. And they used relatively good pressures with an EPAP of 10 centimetres of water at least, and an inspiratory positive airways pressure of at least 20 centimetres of water. So from the evidence base with regards to IPPB, I've explained to you that we're aiming to augment lung expansion, and we can see that we do that. This in turn will recruit collapsed alveoli and utilise collateral ventilation. And early studies showed that there were improvements in ventilation and arterial blood gases, but you needed to use a high enough flow and pressure in order to achieve that. And if the patient was relaxed with the technique, it was also reported to decrease the work of breathing. Now, there are various different IPPB devices on the market, and this brings back lovely memories of being up in the middle of the night setting up the Bird Mark 7. So this is the device that I have historically used for many years. Now, as I've said, IPPB has been around for a long time. And Joy Higgs in 1979 said that there are many forms of physiotherapy able to assist in the treatment of medical and surgical conditions. These include manual methods of secretion removal, incentive spirometry, deep breathing, IPPB, and the effectiveness of these techniques, including IPPB, will depend on selection of the patient and the efficient application of therapy. And I think that that is a really good point to remember, because we're going to keep coming back to this theme with regards to where we see IPPB. So if we look at the evidence base in specific disease groups now, looking at stable COPD, early studies showed no change in pulmonary function, post-spirometry after use, or difference in hospitalizations or mortality. But that study, only 50% of the population adhered to the protocol. In acute COPD, there was improvements in oxygenation, perhaps because all the earlier devices ran off walled oxygen therapy. But if you used IPPB with a nasal mask, it resulted in improvements in arterial blood gases, because you're going down more of the non-invasive ventilation line. If we look at the evidence base in the surgical patient, there has been no benefit found using it routinely post-abdominal or cardiac thoracic surgery, and this is based on early studies and one more recent from 2011. If we look at IPPB and drug delivery, because the earlier devices had the ability to have a nebulization chamber, that there was no significant difference whether you on the major outcomes and variables, whether you used IPPB. And that potentially is because we know that IPPB nebulization deposits 32% less than a handheld nebulizer, and that was work done in 1977. So you need to think about how far compressors and nebulization has come since then. So this device is not really aimed anymore for drug delivery. So based on early work, the American Association of Respiratory Care, so the respiratory therapists, provided clinical guidelines. And they stated that IPPB should be used in the following situations: in the presence of significant pulmonary atelectasis, when other forms of therapy, such as what we've stated before, incentive spirometry, chest physio, deep breathing exercises, and positive airways pressure. So it can target patients where they are having complicated problems and that they're unable to clear. And this is usually because the pathology limits their ability to ventilate adequately or take deep breaths, i.e. they're fatigued or that they have a weak cough. It can also be used to provide a chest wall stretch. Now, 6 years later, the British Thoracic Society guidelines were published in the spontaneously breathing patient, and they looked at a whole host of techniques and provided advice and recommendations around their use. And what I've done is I've taken the intermittent positive pressure breathing recommendations for each disease group that they talked about. So, as I stated at the start, in order to achieve therapeutic effect, your IPPB needs to be set to give a deeper breath in or an increased tidal volume than the patient can take themselves. And that's their recommendation for COPD. You should achieve synchrony with the patient to reduce the work of breathing, and that short periods of intermittent positive breathing should be used to treat chronic respiratory failure and stable state COPD. Should not be used to treat chronic respiratory failure and stable COPD. You should consider IPPB in the acute exacerbation where patients present with retained secretions but are too weak or tired to generate an effective cough. So this is the theme that is coming through for the evidence base for IPPB. And when using devices that connect to the wall, an FiO2 of 0.4 could be used. If we look at CF, again, it could be used as an airway clearance method as an alternative to non-invasive ventilation, where there are indications for non-invasive ventilation in that situation exist. In non-CF bronchiectasis, again, consider it to augment a greater tidal volume and reduce the work of breathing in patients that are fatigued and find airway clearance difficult, because you'll be considering offsetting the increased load of breathing by providing ventilatory support. And that there's no evidence base for it to be used in uncomplicated, straightforward pneumonia. I think we just need to be mindful of this technique in that this is the evidence for, this is the recommendations with regards to workforce provision of different techniques. And when it comes down to non-invasive ventilation, so this is a blown up part of this table, CPAP, NIV and IPPB setup in an uncomplicated patient will take around about an hour, and the same for a complicated patient. For further treatment, it's half an hour in an uncomplicated treatment and an hour in a complicated treatment. So you have to have the workforce to provide this technique because it's about providing it competently and effectively to get the best outcome, and that has been highlighted throughout. In a more recent study by the Italian group led by Antonelli Nicolini, he looked at 15 patients who received IPPB twice a day for 30 minutes. And what he found was that there was an improvement in the MRC, the Medical Research Council Scale for Breathlessness, and the CAT-COP assessment test, which is a quality of life score. And the IPPB had a greater effect on dyspnea and quality of life than their other treatment, which was TPEP. Now, we've said that IPPB can be used to mobilise secretions, but it has been shown to augment cough. And this is work in a group of children with neuromuscular disease. And compared to their baseline cough strength, after a deep breath in with an IPPB device, there was an improvement in their cough strength and an improvement in their lung volumes. The American Association of Respiratory Care highlighted that it can be used for chest wall stretching, and I think that people know that I often show this slide, but it does show that positive pressure at greater than tidal volumes than can be delivered by the individual themselves improves chest wall profile, chest wall stretch. And we all know as physiotherapists, we want to have a compliant chest in order to optimize our airway clearance techniques. So based on the evidence that I've been through, and to highlight again the clinical guidelines that I've reported, patient selection is those that are fatigued and have an increased work of breathing and decreased tidal volumes. And if you are seeing that in your patient groups, then IPPB can be a treatment option. And it can be used in COPD, cystic fibrosis, bronchiectasis, neuromuscular diseases, post-thoracic and abdominal surgery, and ICU-induced weakness. And if you're looking to improve cough, you have the neuromuscular population. Just to say that from the ENMC workshop, when we're looking at just providing a deep breath in or cough to improve cough, we are targeting a cough peak flow or peak cough flow of 350 litres to around about 130. So anyone over the age of 12 that has a cough strength in that category has the potential to benefit from an IPPB assisted cough. With any technique, there are contraindications and relative ones. So just to highlight the major ones, it's around pneumothorax, especially attention pneumothorax, and surgical emphysema of an unknown cause. You'll have local policies for your other relative contraindications, and I won't go through these in detail. So let's look at IPPB as an airway clearance tool. And again, I often show this slide, but this slide is so beneficial for our way of thinking about what are we doing. And Louise Lanafors looked and broke down how we need to target patients to clear secretions. And in this 4-step process, she highlighted that firstly, we need to get air behind the mucus to open up the airways. We then need to move it slightly further in to loosen and unstick the secretions from the small airways so that they can be mobilised to the larger airways. And once they go from the larger airways, they can be mobilised to the central airway and cleared with a cough. And we know that stage 1, 2, and 3 can be described as peripheral airway clearance techniques, and stage 4 is proximal airway clearance techniques. And often what you end up doing is you have a cycle. So you've got your 4 stages, but you keep going round and round. So let's just look at where we're putting IPPB in our airway clearance techniques from a peripheral perspective. So it sits within the device category. But it's important to remember that often we do not deliver IPPB on its own. We combine this with other techniques. And that might be modifying the active cycle of breathing techniques and adding in postural drainage and manual techniques. And the way that that happens is, as I said, we're often, if we look at the active cycle of breathing techniques, having relaxed breathing followed by deep breathing, and then breathing control, the forced expiration technique, and cycling and adding in these techniques. We can use intermittent positive pressure breathing to support the thoracic expansion exercises. We can use it to augment the tidal volume, and we can add in our manual techniques. Let's just take a moment to look at this in action. So the positive pressure has been delivered, and we are seeing a rise and fall in the chest wall, which is greater than the individual can do themselves. Their shoulders are relaxed, and it may be that you need to use nose clips to prevent nose leak from the air going up the upper airway. This is an example of adding in the manual techniques. So again, we're having greater chest wall expansion, but we're using manual techniques to mobilise the secretions further. If we're using it as a proximal airway clearance technique to augment cough, then what we're using it for is the cough part. So we're using it to provide a deep breath in, and then the individual will cough afterwards. So How do we apply IPPB in the Clearway 2? Now, as I said, this device here was the one that I trained with. It plugs into an oxygen source and mixes in air. We knew that we needed to be careful with those patients that have oxygen sensitivity. The Clearway 2 does not attach to the wall and to a direct source of oxygen. It's delivered via the air compressor in the device. And if we want to entrain oxygen, we do this via the circuit, similar to how you can do with a non-invasive ventilation device. And like any technique where you're using oxygen therapy, you only want to entrain enough oxygen therapy to meet the target saturation that has been prescribed. We have various different circuits for IPPB, but the first one is a straight 22mm bore tubing that is attached to a leak, because what we don't want to do is breathe everything back inside the tubing where it will just come back to the patient. So this is where we are venting out our expiratory airflow. We've already highlighted that IPPB is not effective at delivering nebulized drugs, but it may be in some situations a patient complains of dryness, and if that is the case and you want to add in nebulized saline, this can be easily done via a T-piece to a nebulized chamber to a compressor. When I was setting up the Bird Mark 7, shown in this picture, typically we would set the inspiratory pressure between 8 and 15 centimetres of water. Always the way your slides then advance when you don't want them to. So we would set 8 to 15 centimetres of water, and we are looking for an increase in our tidal volume, and we would increase the pressure up to what was required. Typically we'd start the flow at the midpoint, which is shown here, and that the trigger was not so sensitive that it was permanently self-triggering, and that could be a particular pain with this device. And our controlled expiratory time was set to off. With the Clearway 2, again, we recommend that you start the pressure between 8 and 15 centimetres of water and titrate up till you achieve that tidal volume that you want. Set the flow to 60 litres per minute at midpoint. You can always increase it or decrease it to lengthen or shorten the time. We know that when we want to utilise the cut channels of collateral ventilation, that a pause or a hold is important, and this can be achieved by setting the plateau on the device. Start at 1 second. If you want a longer plateau, increase it. If you want a shorter plateau, decrease it. The device is fairly sensitive, and so I would start at around about 5 and see if the patient can easily trigger the device. If they're having to suck really hard on it, then you will make it more sensitive. If it's self-triggering, you can make it less sensitive. When we're targeting a cough, we're looking for a deeper breath in than just supporting, than that 25% more than supporting ventilation, which we're trying to achieve for secretion mobilizing. So we want to get near to the lung insufflation capacity. So we want to get nearer a deep breath in. We don't need to maximally insufflate or give a maximal deep breath in for a patient. And this was identified by Mellis and co-workers in this study, looking at what pressures were required to increase the most. And this is increasing your pressure on the IPPB device in different patients. And you can see that some patients just have an optimal pressure for increasing their inspiratory volume that is lower than the maximum pressure they can take. And what they did was they looked at the vital capacities compared to baseline and giving the maximum amount of air that the patient could hold versus the optimal. And the optimal air amount of air, which produced the greatest change in cough strength, was lower than that of the maximum insufflation capacity. And that's done in both of the situations, IPPB and a lung LIAM manoeuvre. So the take-home message from this is that yes, we're looking for a deep breath in, but we're not looking to absolutely take the patient right up to the maximum amount of air that they can hold within their airway when we're using the device to augment a cough. With regards to coughing, we're looking at starting with higher pressures than that of peripheral airway clearance techniques. And so you can start between 12 and 20 centimetres of water and again titrate up. Again, the flow in the midpoint and change depending on patient comfort. But again, you're probably looking at a slightly longer plateau in order to hold them there so that they can cough. But again, this will be patient dependent and the trigger around the same starting pressure. Although bear in mind that often when we're looking to improve cough strength, we have neuromuscular patients that may need the trigger to be more sensitive. Stepped insufflations is a new feature on the Clearway 2. It is within the mechanical insufflation exsufflation mode of this device. And if we look at what happens when we are using stepped insufflations, I'm going to show you the lung model with it being used, but you can see on the screen that stepped insufflations increase the inspiratory pressure over a certain amount of breaths, followed by a switch to exsufflation to negative pressure. So the breath will go in and hold, and each breath it will get slightly more. And then it will provide an exsufflation. So this is just a highlighted version of the screen and where you can see whether you've got your stepped insufflations on. When you go into this, you can just either have them straight, which means it's off, or stepped here. To clarify, the first insufflation will be 50% of the target pressure. So the insufflation pressure is 35 centimetres of water, that's the target. And so it will be half of that. And I don't know if my maths is going to work it out, but it's probably 17.5 if I've got that right. You can answers on the Q&A later. It will then rise in incremental increments depending on the amount of breaths that you've set. And the final pressure here is 35 centimetres of water. So it can be useful if you're trying to provide a chest wall stretch and someone's quite sensitive to having a strong deep breath in at the start. It can also be useful in patients that tend to feel like they're hyperventilating, that they might feel dizzy with using positive pressure because they hyperventilate with insufflations, or if you're trying to achieve lung recruitment. So here's the technique being used, and you can see as the video advances that there will be slowly a greater chest wall movement each breath, followed by the exhalation. So we've been through the evidence base for IPPB and where potentially we can use it and some of the features on the Clearway 2. Now, Julia Bott, Kilty and Noon wrote this nearly 20 years ago. No, 30 years ago. See, my maths is atrocious today. What really strikes home is that I probably would say the same thing today as that they are saying now. IPPB is a useful adjunct to chest physiotherapy techniques, provided we take account of the reported advantages and disadvantages and use it appropriately. The physiological effects cannot be ignored. We know that it improves tidal volume, it will recruit lung and utilise collateral channels of ventilation, especially in the patients that are weak. They were highlighting that this can be used for avoidance of intubation and ventilation if desirable. The skills of the physiotherapist and adjuncts that he or she has available, such as IPPB, may well be sufficient in many cases. As a profession, we should not allow a useful adjunct to our treatment to slip into disuse on the basis of such inclusive evidence as reported with IPPB. There is reasonable evidence that IPPB remains a very useful, worthwhile piece of equipment. And as I've said, I totally agree with this statement. And as older IPPB devices become less available, it's really useful to know that there are other alternatives out there. To summarise, IPPB is a useful tool when you need to augment tidal volumes to achieve effective airway clearance. It can be used to enhance cough or mobilise secretions to the central airways in patients particularly that are weak or fatigued. And the stepped insufflations on the Clearway 2 can be useful if you're looking for chest wall stretching or to acclimatise patients to higher pressures. And for those of you out there using the device, you may have also found that it's particularly useful for other things. And again, please do share in the Q&A. Education by Briaz offers lots of educational resources on how to use these techniques, and you can use this QR code to go there. Our next webinar next month is on the 30th of September, and Christophe Perrin will be talking about how to use ventilator integrated polygraphy. And again, there's a QR code should you wish to register for that. So I'd like to thank you for your attention, and I will stop sharing my screen now and ask if there is any questions at all.
Hi, Michelle. Yeah, thank you for a very informative talk. I think you did a great job bringing this from the theory over the scientific evidence to the real life application. Great talk, thank you. There's a number of questions. I'll start with the longest one, if that's okay for you. So there is one, the longest one here. Hi, Michelle. We have a cough clinic that we run, and we mainly see neuromuscular patients. When we look at their pickup flow, if it's around 160, could you alternate cuff assist and IPPB on the Clearway 2 for treatments to help with chest wall stretch and secretion clearance?
That's a really good question.
Sorry, it's already long, but it wasn't the whole question.
Am I going to remember both parts? Do we need to?
Yeah, maybe, yeah, take this one first. I'll have the remaining part as a follow-up question.
Okay, perfect. So yes, you can alternate between IPPB and MIE, and you can almost, I think that's really useful if you have some of the Duchenne patients that have some secretions always sitting there, and that you do need to get things up a little bit higher. And the SMAs are also another example. So you need to mobilize it up and then you need to cough and clear it. I noted that you did ask about chest wall stretch. It depends on how competent the team is. And you have some carers in the community that are like amazing. And then that you have other ones that get very flustered about even swapping from one thing to the other, bearing in mind that potentially you may have different circuits. So if you are looking for a chest wall stretch, I would just say with mechanical insufflation, exsufflation, you can just let the patient have a deep breath in and let it suck out and let that cycle repeat without them coughing. Sometimes it's easier said than done, but I think that you can use both options depending on what fits your patient and their family group. And the second part?
So some of these patients haven't started on NIV yet, but would adding IPPB help with increasing tidal volumes? Not a long-term solution, but would it help with tidal volumes?
Yes, it definitely would. And if they're not on NIV, also you'll be improving chest wall compliance, lung compliance, you'll have added benefits, and you will be acclimatizing them to using NIV down the line. And I think that that switch then doesn't become such a shock to the patient, and they sort of know where they're going, and they feel more comfortable about it. So I think that that could be a really good tool to be using. And I think, like you seem to be in your practice, being proactive rather than reactive is key nowadays.
Thank you. A short one. How to find and define the optimum insufflation capacity with IPPB?
Yeah, so what you're really looking at is listening to the cough strength afterwards and just taking on board what your patient says with regards to how they are feeling comfort-wise with the breath. Often what you'll see is you'll look at the patient and it will still be coming in and they look like they want to breathe out. They can't actually hold all of that in order to be comfortable and up there. And when you, I keep wanting to say insufflate, but we're not in MIE mode. So when you give that deep breath in, that inspiratory volume, you can see that they get to this point and that they're just sort of losing the air. So you just want to take that little bit of a step back. I'm afraid there's no magic beep on the device that tells you you've gone too far.
Yeah. Also, again, in relation to IPPB and the combination with other therapies, can you combine inspiratory assistance with IPPB with, and I think it was the open field missing or not highlighted on your slide. So can you use IPPB with expiratory techniques such as a flutter, for example? So
unfortunately, the Clearway 2, that is not possible to do because you can't connect it. However, if you are looking at a device that uses, for example, the intersurgical disposable circuit, which the Alpha device uses, and the Bird Mark 7, you can attach a PEEP valve onto the expiratory valve of that circuit. So it is very dependent on what device you are using because of the circuit.
Another one, in the videos and on the photos, all IPPB circuits are equipped with a mouthpiece. What is your experience with using a oronasal mask?
Yeah, so using an oral nasal mask is absolutely fine, and you may be doing that in neuromuscular patients that physically cannot hold a mouthpiece. But clinically, I've found that if the patient has no difficulty sealing around the mouthpiece and can tolerate nose clips, if they have a bit of nose leak, you tend to find that down the line you can get rid of the nose clips because they actually can hold the air. It's just something at the start. Using a mouthpiece will be more effective. You will get a better tidal volume into the patient and it's more comfortable for them than having to hold a mask on their face. So the two situations tend to be masks for neuromuscular that can't hold the mouthpiece, and mouthpieces for the rest of the diagnostic population that we've talked about today.
Okay, two very similar questions, so I'll list them both at the same time. One is if you have experience and tips and tricks using IPPB or MIE with patients with learning difficulties. And then a very similar question is if IPPB can be used with patients that have as good as no active cooperation.
So IPPB can be used with patients that don't have active cooperation as long as they're triggering the device. So as long as they have the strength to trigger the device, you can use it. What you need to do is evaluate closely over whether when the inspiratory flow goes to the patient, does it make them breath hold? Do they fight it? If they don't, and they let the device sort of take over and give them a deep breath in, it will help with your treatment. However, if just the airflow stimulates them to breath hold, fight the device, then you will find that this is not the treatment technique for you. The same with learning difficulties. It depends on the severity of the learning difficulty. Some patients with coaching, you will find that they will be able to eventually understand the technique and be able to cooperate with it. If the learning difficulty is so severe, you're in the sort of uncooperative line, and it's about trying it if they can trigger it, but it doesn't cause an increase in tone and airway, sort of airway closure is not quite the right word, but it's a combination of cognitive and them holding the airway. If that's just not working, then no, stop. It's IPPB is an art, not a science. Try it, modify it, but if you're failing, don't crack on.
Okay, great. About stepped insufflations, can stepped insufflation be used for actual treatment, or is it only a tool to initiate and get the patient used to higher levels of positive pressure?
I think the answer to that is both, in that you can use it to get people used to it, and you can use it if that's the only way that they can use the device and you can get the pressure up as a treatment method for them. I think you might just need to be slightly mindful around if a patient does need a high insufflation and exsufflation pressure to cough, is that last one going to be enough? So it's that balance of, are you using it for chest wall stretching and just to mobilize things, or are you using it as a cough augmentation technique? And the answer is, if the patient is reliant on clearing their secretions straight away, then no, I wouldn't be using it in that way, because it's not going to deliver or give them the option of enough cycles to clear, and you may find that you get an overwhelming amount of secretions that are stuck in the central airway and that you're then trying to clear it. So I would say that if you're using it to acclimatize or to slowly mobilize stuff up, absolutely fine. But if the patient needs to cough and clear immediately, it wouldn't be my treatment mode of choice.
The last one is probably a more technical question around the stepped insufflations on Clearway 2. The question is, if when using these stepped insufflations, is the first step always delivered at 50% of the final pressure, or is there a choice?
So I'm going to invite Phil Houghton to join and answer this question, because he is the product manager for this and knows all of the technical answers. I can hazard a guess and say that there isn't a choice, but I wouldn't know the answer for sure, and Phil does. Okay,
welcome, Phil.
Hi. Yeah, you're absolutely correct, Michelle. There is not a choice, so it's always 50% of the set pressure the first breath is delivered at, and it's always rising in equal increments depending on the number of insufflations that you have set.
And the range of stepped insufflations goes between?
Very quickly, I think it's up to 10 insufflations. So that's the maximum number of repeatable insufflations that you can program in an MIE mode. So, and then it will always be, as I say, an equal increment per insufflation. So I don't know what I would probably wonder about. I have wondered about this, Michelle, and perhaps you can answer this, is are there probably a more ideal number of repeated insufflations to do? Because of course, if you just have 2 repeated insufflations, then you may go from 20 centimeters one breath up to 40 centimeters the next breath, for example. So would you want increments of no more than 5 centimeters perhaps, and should that be in your thinking when setting it up?
For me, if I'm acclimatizing someone to it, then it's looking at more breaths. So I wouldn't be using 2 stepped insufflations, because you're right, it is a big sort of shock that you've gone from X to Y, like in 2. So for me, I would be using 5 to 10 insufflations to get someone to where I want to be.
Okay.
People
So-
always have a wish list, however, Phil, and they can add that to the Q&A and you can take that away.
Yes.
Good. No further questions here on the chat, Michelle. Once again, thank you for this very informative talk about a very specific topic, but you covered it nicely. That being said, I'd like to invite all of you already now for our next webinar. The webinar will be on, again, the last Thursday of the month, being September 30th. And it will again be on ventilation, and this time the September and October webinars will be like a small series, because both of them will be around the use of ventilator integrated polygraphy. So not as on the slide, it's not with the same topic again, but we'll have a topic on ventilator integrated polygraphy, where during the first webinar, Christophe Perrin from the Centre Hospitalier Princesse Grasse in Monaco will talk about the theory and how to read polygraphy tracings under NIV, which is not exactly the same as for spontaneous breathing patients. And then in the October webinar, Jean-Michel Arnal from Toulon in France will take that theory into the practice, and we'll look at a number of patient cases and examples. So please scan the QR code or write it down in your diary. September 30, we will have our next webinar. Follow us on our social media channels, at Breas Medical on Twitter, and you'll get a number of updates on the forthcoming educational activities. And last but not least, if you're interested in more product application videos or looking for educational material, don't forget to visit us on educationbybreas.com. Thank you very much for your attendance today. Hope to meet you all next month for our next webinar. Thank you for joining.